At first, I was invited, and the topic of my title is the role of pneumococcal polysaccharide vaccine in the prevention of pneumococcal disease. The first thought hit my mind is a question: is there any role of pneumococcal polysaccharide vaccine for children in the era of pneumococcal conjugate vaccine? So, from the question, we may translate to two questions. The first is which children should receive PPV 23 in addition to PCV 13, and at what age should we receive it? From the research, we can see, according to CDC US recommendation, PPV 23 is recommended for children with immunocompromised condition, functional or anatomical asplenia, and also for immune-competent children, but with chronic lung, heart disease or diabetes, and CSF, leg and cochlear implant. And for those children aged 2 years and older, should receive one dose of PPV 23 after the final dose of PCV 13. And also for children with some immunocompromised condition, maybe receive the second dose of PPV 23. It is true. We may search the paper. The recommendation is appropriate. So my talk. But before we search the paper, we can see that U.S. recommendation for PPV 23, not only by ACIPID but also by AAP recommendation. You can see here they recommend a different condition, PPV 13 and 23. And AAP support, but different kind of condition. They recommend is different kind, and also they recommend is 8 weeks apart after the last dosage of PCV 13. So there's maybe my talk will focus the outline, the question. Also, as you may know, polysaccharide vaccine is T-cell independent. It's T-cell independent, but the carrier protein, the conjugate vaccine is T-cell dependent. With the T-cell dependent, conjugate vaccine can be induce memory B cell and also have a booster effect, and also immunogenic in infants, and had long-term body response. Also, in previous speakers say reduced coagulation and also had immunity. In addition to carrier protein, there's some difference. For conjugate vaccine, the antigen is relatively low, but in the PPV23 is quite high, even 10-fold antigen in the different. They also, the coverage serotype is different, but the 23 is no 6A compared with PCV13. So is that for IPT children in the era of conjugate vaccine, how about the risk factor? There's the one study in the conjugate vaccine, PCV7 era. There's a case control study. They include the IPT cases during 2001 and 4, and identify one case match 3 control, and also they enrolled nearly 800 cases and more than 2,500 match control cases. And the summary they can see for those with receive any PCV7, the increased risk factor for vaccine type IPD cases if they had underlying illness. Also, they are male or have no healthcare coverage. For those with under illness, increased risk, also non-vaccine serotype. We can see here the chronic lung, chronic condition, and also immunocompromised condition. Especially for the immunocompromised condition, there are 11 odds ratio is nearly 5 rate ratio increase for the IPD cases. And also in multivariant condition, if for those with vaccinated, the increased risk is nearly 24 odds, but for unvaccinated is a four-fold increased risk. So in this study, they can show presence underneath. It indeed is a significant risk factor. Even the children have received PCV7 vaccination. Also remember, we should remain suspicion of IPD. And so additional serotype coverage is important. And also in the PCV7 conjugation, the CDC ABC core surveillance data from 2007 to 9, they found aged these age children have for those receive the children is more than 50% of IPT cause serotype included in PCV7. For immunocompromised patient, additional 23% serotype increase in PCV. About the additional risk factor, you can see here for those with hematological malignancy is increased nearly 800 rate ratio increase the risk. For HIV is more than 100 risk ratio increase the fold, and also sickle cell disease. So once again, at risk factor is very important for the IPD infection. There's a recent study published from the Massachusetts study group. It's an observational study. They compare pre-vaccine 13 and the post-vaccine 13. They can see in the first 2 years of PCV 13 use, the serotype declined by nearly 20%. But we can see here, for those children with underlying disease, pre-vaccine phase and after vaccine phase, no significant difference change between the two periods. But for about non-vaccine serotype, the comorbidity had a higher rate, but the significance also marginal significant. But for those cases with comorbidity, they're more likely to be hospitalized and also have a longer hospitalization. So the study show here in children with underlying condition, the maybe non-vaccine serotype more common, and also the routine PCV17 may not enough to reduce the risk in patient comorbidity. So here, how about is there any efficacy of effective data of PPV7 in children? I try to search from the PubMed, but I can find one study. So there's just several studies in adult. So I just can show you the data in the adult. There's a population-based retrospect study in US. There's the data showed a significant reduction of pneumococcal bacteremia cases, but no reduction in community-acquired pneumonia cases. So you can see here only pneumococcal bacteremia decreased. Reduce around 50% of cases, the risk. There's another study just published 2 years ago from Spain. Spain, there's they enrolled more than 27,000 individuals aged 60 years. And also the primary outcome is hospitalization for pneumococcal community-acquired pneumonia, including bacteremia and non-bacteremia, and also all cause of CAP cases. We can see here in the primary analysis, including all cohort members, PPV23 not appear to be effective against any analyzed outcome. But after a multivariable adjustment, the recent vaccination with PPV23 less than 5 years, they associate with reduced risk. For bacteremia, pneumococcus, CAP, non-bacteremia, overall CAP is decreased, reduced. So in this study, we can see here, there's a protective effect, just recent. Within previous 5 years, can reduce, PPV23 vaccination can reduce. So the need, this study suggests the need for vaccination in this group. Also, how about, since there's no efficacy and effective data of PPV in children, so we try to search some immunogenicity data. This is in the study is conducted in Fiji. Infants age 6 or stratified by they receive a different kind PCV7, receive 0 dose, 1 dose, 2 dose, and 3 dose, and then stratified by at 12 months of age we receive PPV23 vaccine booster. So there's totally an 8 group. We can see here the different 8 group, and it's a complicated, but I think we just for those receive one dose of PPV23 at age 12. We can see here previously received 3 PCV7 and boosted by PPV23 increased markedly. Different cut of protective seroprotective level, and also two doses previously, and even 1 dose previously. And also this even higher than those receiving 2 or 3 doses PCV. So this study, the major finding is PPV23 at 12 months induced excellent booster response following 1, 2, 3 doses of PCV in infancy of all PCV7, and also significant in non-PCV7 serotype, also significant response. It's interesting. The booster response is greatest for only receive 1 dose of PCV7 in the infancy compared to 2 or 3 doses of PCV7. The study also, this study also compared the OPA opsonophagocytic activity in the same design is also include age group, but they for half the patient receive PPV23, and all patients receive a small dose polysaccharide vaccine at 17 months of age. All OPA or receive serotype. The major finding is for those received 3 or 2 PCV7 doses result is similar OPA at age of 9 months, but at the age of 12 months, the proportion of infant with seroprotein level was significantly higher in 3 doses group than to 2 doses group. But only 1 single dose also improved OPA compared with non-vaccination. The important is PPV23 also significantly improved OPA for all serotypes. But in general, if they receive the small dose PPV at the age of 13, the diminished response following rechallenge. So in the short interval for the revaccination, maybe it's not needed for this group. How about in some had underlying disease, the immunogenicity data? This study include more than 170 patients. They divided by disease pattern, receive cochlear implants. The P1 group is meningitis, P2 is cranial malformation, the unknown cause, and also P4 is for healthy control. And by age, they stratify by less than 2 years, 2 to 5, and more than 5 years of age. The group A1, this age group is receive PCV7, and H2, 1/2 receive 7 and 1/2 receive 23, and A3 group receive PPV 23. We can see here before vaccination, in the P1 group, the IgG titer, IgG subclass 1, and also IgM titer rarely controlled by control group is a healthy control group. But irrespective of the underlying condition, all patients show a sufficient antibody response after 1 dose. So you can see here, post-vaccination, the rate is more than achieve seroprotective rate. But in age 2 to 5 years of age, PCV7 was significantly more immunogenic than PPV for several types, but not all serotypes. For serotype, it did more immunogenic than PPV23. So in this study, PCV7 should be, the author recommend not only for younger than 6 years of age, but also older than 6 years of age who are at risk, increased risk of bacterial meningitis. Also, if the cochlear transplant recipient with a history of bacterial meningitis, maybe should undergo immunological evaluation, because some data show decrease, maybe have a defect in human immunity. This study also the similar design as the previous one. This evaluate 145 children investigated for recurrent and also severe infection. Among them, 12 cases found to have a really clinical associated with significant defect in human immunity. So this study showed that the children, all the children received 2 doses of PCV7 and 1 dose PPV23 is among IgG subclass 1 response. But for IgG subclass 2 is no increase. So for PCV7 vaccination, maybe the response is IgG subclass 1, not IgG subclass 2. But this study also found a specific finding is for those receive PCV7 and sequentially by PPV23, the serotype not covered by PCV7 remains low for the IgG response. So this study suggests this is a data not increased in the serotype, not included in the PCV7, but the other type yes increased. So the study say the authors conclude that for children after PCV7 received a PCV7 conjugate vaccine, the immune response is in IgG subclass 1, but not 2. But for those PPV and also natural infection, the antibody response is IgG2 subclass. And also the authors conclude that PPV23 didn't broaden protection against a PCV7 serotype. But in some population, you can see here for preschool asthmatic children, this study include 70 preschool asthmatic cases. One half of the case they receive one dose PCV7 and followed by PPV23. Among them, half of the vaccine received PPV23 8 weeks after PCV7, but the other group received 10 months interval. This group B, we can see this is 8 weeks. This is 10 months. Pre-vaccine for both groups, nearly 80% didn't reach seroprotective antibody. But after immunization, all cases immunogenic, inducing seroprotection in the majority of the children. We can see here, this is not include the PCV7, but also increased markedly. But for B group, for some serotype, we can see here the B group is increased then higher than the A group. It means this study shows there's no evidence for hyporesponsiveness for pneumococcal polysaccharide vaccine immunization. And also the time interval is very important between PCV7 and PPV23 should be longer than 2 months in order to achieve base immunogenicity. So if the interval is too short, maybe the immunogenicity is not so good. How about the clinical practice in the pediatrician? This study is conducted in sickle cell disease. In the institute, they include the pneumococcal vaccine strategies PCV7 and all 13, followed by PPV23 at 2 and 5 years of age, and then every 5 years later. And they define for those with good responder, if their seroprotective level of IgG at least 50% coverage of the 23, it means if there's more than no less than 12 serotype test is elevated, is good responder. Otherwise, it's poor responder. You can see here, 2/3 receive PCV7 followed by PPV23, and 1/3 receive PPV23 only. And this, the major finding in this study is there's a significant percentage of person with sickle cell disease didn't maintain a sufficient vaccination response to PPV23 for 5 years, and only nearly 1/3 of patients have protective level at the average of 3 years after vaccination. So they also there's a finding also there's no difference between who received PCV7 followed by PPV23 or only receive PPV23 only. There's no difference. And also there's no difference between only one dose of PPV23 or multiple doses of PPV23. So they found time since the last PPV23 is significantly predictive in all statistical analysis. So maybe the revaccination is also important in this group. So the author conclude is that immunity may not be optimally maintained in patients with sickle cell disease. So revaccination may be important. But they also suggest that further investigation is very important. My summary is, it's true, the presence of underlying illness remains a significant factor for IPD, regardless of vaccination or non-vaccinating serotype, even in children who received PCV. PPV23 provide protective effect against pneumococcal disease in elderly, but a clinical protection wanes after 5 years, but there's no data for children. Immunogenicity data of PPV following PCV in children in normal host is seen the response as previously seems good, but at risk population, depending on the underlying disease the children have, some is good, some is not, and also children at age 2 to 18 years at risk of IPD should receive PCV starting first, and then maybe broadened by the following PPV23 in some conditions, but the interval should be longer than 8 weeks, maybe several months later for the PPV23, and the revaccination may be needed in some conditions. Thanks.